So the goals of what we're going to talk about today, first thing we want to do is just clearly define injuries in both an acute and chronic sense and how they relate to barbell training. We are going to look at some relevant research that's been published on the topic, and then we're going to look at common pathologies that you can expect to see in your client population, okay? So this is a Starting Strength Coaches Association conference. In Starting Strength, RIP defined some of these things for us. So as all of us know, who's trained for any amount of time, you're going to get sore. Eventually, if you train hard enough, you're going to get hurt, right? Anybody in here never have an injury? Yeah. Carl, never hurt yourself? How long have you been training?
4 years.
4 years. Okay. Some people, as you guys probably know from working with your clients, have injuries kind of creep up more easily than others, right? We have some people in here who hurt themselves doing relatively insignificant things, and other people who, more difficult time accumulating injuries. But in terms of soreness, it's important us to define for our clients the difference between soreness and injuries, right? How many of you guys here have ever had a new client who'd never really trained before, who mistakenly thought that being sore meant something really bad had happened to them, right? So you have to go through this process of explaining to them, what's going on here. An injury is something that happens to the body that causes pain in a way that is not the normal consequence of correctly performed training, okay? An acute injury versus a chronic injury. An acute injury is immediately perceived as pain or discomfort in an identifiable structure, right? Any of you guys ever start a training session and all of a sudden something doesn't feel right, right? You have a sharp pain in your knee, or your back hurts, or your hip doesn't feel right, whatever it is. That's an indication that there could be something acute going on, versus a chronic injury, which is an inflammatory response, generally to overuse or mechanical loading. A lot of times it's a misapplication of training or programming. And in terms of safety of barbell training, we're going to look at the relatively few studies that I could find on the topic and try and correlate it to what we're going to talk about for the rest of the lecture, okay? So we're familiar with some of the stuff that's out there, but hopefully some of these things you guys haven't seen before. So barbell training safety, this Hamel study from 1994 is the one that RIP uses in Starting Strength, right? You get that nice little chart that shows you the injury rates of all these various sports and endurance training activities in relation to general resistance training, weightlifting, competitive powerlifting, that sort of thing. So it was a questionnaire used to survey injury rates among 13 to 16-year-old students who were receiving instruction into weight training and weightlifting. And the overall injury rate for weight training and weightlifting was 0.0012 per 100 participant hours, which was far lower than any typical team sport, right? Things that your clients probably participate in, recreational sports, endurance activities. I can tell you from the standpoint of being a physical therapist, I can maybe think of, we had one competitive weightlifter come in who had ankle surgery that was unrelated to his training. Occasionally, we get powerlifters who have, overuse type injuries come to see us because they kind of know that we're the only physical therapists in the area who deal with this stuff. And then we get, CrossFit people who come in and have injuries related to barbell training. But in general, I can tell you I see far more people who hurt themselves playing any other sport you can think of, right? I see ACL tears related to soccer, basketball. I see shoulder surgeries related to tennis, baseball, softball, elbow reconstructions, all those things that happen in everything else that's not barbell training, right? So this study by Calhoun in 1999, injury rates and profiles of elite competitive weightlifters. So this is looking at a particular population where lifting is their primary objective, right? The only thing they really care about is how much weight they're lifting in the competitive lifts. So they collected and analyzed medical records of resident athletes in U.S. Olympic training centers over a 6-year period. They found that back, knees, and shoulders accounted for the most significant number of injuries, 64.8%. Again, as a physical therapist, I can tell you, I see a lot of back, knees, and shoulders, very high percentage of back, knee, and shoulder patients who have never touched a barbell before. So it's kind of in line with what we see in the general population, right? These are joints that just tend to get injured. Rates of acute and recurring injuries were calculated to be 3.3 injuries per 1,000 hours of weightlifting exposure. And 90.5% of the injuries recorded required less than 1 day of missed training time. I think the term they used was 1 day or fewer. So this study in 1999, the next two studies actually, I think were by the same research group who actually took information from that same organization that Sully referenced in the Valsalva lawsuit. So the U.S. Consumer Product Safety Commission's National Electronic Injury Surveillance System, okay? So they analyzed sex differences in weightlifting injuries presented to U.S. emergency rooms between 2002 and 2005. 3,713 patients went to emergency rooms for injuries related to weightlifting. This is recreational weight training, resistance training, Cybex training, anything that can be classified as weight training or weightlifting, right? So what they found is males had significantly more sprains and strains, primarily in the trunk region. Females had more foot and leg injuries. And the conclusion was males have more exertional type injuries, whereas females were more susceptible to injuries via an accident, okay? So, you know, what I have in my head when I read this was that your typical gym bro, right? I know a lot of you guys aren't in commercial gyms. I, in New York, have trained in commercial gyms for the last 15 years of my life, right? More males hurt themselves trying to pull 315 off the floor in complete spinal flexion, right? They have injuries to their trunk, whereas girls drop a weight on their foot while they're like putting up an Instagram hashtag. You know what I mean? So that's like the image I have in my mind. And if you guys know my girlfriend, you know what I'm talking about, right? So barbell training safety, this is that same group. So what they also did with their data is they looked at the incidence of weightlifting injuries, youth versus adult. So they had 4,111 subjects between 8 and 30 years old who went to the ER again. So what they found, accidental injuries decrease with age, while sprains and strains increase with age. That kind of makes sense, right? I think this is the last one. So resistance training among young athletes, safety, efficacy, and injury prevention by Feigenbaum, not our Feigenbaum, a different Feigenbaum. Evaluate a resistance exercise as well as weightlifting and powerlifting, right? It's a literature review. Majority of injuries in young lifters can be classified as accidental. And I think the important point that was made is that no injury to the growth cartilage has been reported in any prospective youth resistance training study that provided professional guidance and instruction, right? So when a young kid comes in and is working with one of you guys, they're going to be relatively safe, right? It's when they're off on their own or working with somebody who maybe is a lot less qualified than a starting strength coach that, you know, the potential for injury increases. So what conclusions can be drawn from these studies? In my opinion, on the whole, resistance training, weightlifting, powerlifting, all these things are relatively safe, especially compared to other team and endurance sports, right? I see way, way, way more runners than I see people who come in saying they hurt themselves squatting or deadlifting. Majority of injuries can be classified as strains, which to me is a very vague type of term, but that's a term that you keep seeing in these studies. Most commonly affected area being the trunk, which to me means the back, right? And followed by the knees and shoulders. Novices to weight training can benefit from having experienced supervision. So nothing really earth-shattering that we can draw from those things. So how does this impact you guys? In my opinion, those studies really don't impact you guys, right? Because when someone's coming to see you, they're having really the highest level, in my opinion, that they can get in terms of supervision and quality instruction and the technical aspects of the lifts, right? So you're not going to have people, you know, blowing out their back on a deadlift when they're coming in to train with you for their linear progression. So where do we go from here? So we understand barbell training is relatively safe, especially when compared to a lot of the other recreational activities that our clients are taking part in. But I think it's important for us as starting strength coaches to understand that many of the people that we are going to be working with already have some type of musculoskeletal pathology, either in their history or that's underlying, that may not have kind of creeped up and become a problem for them yet, right? So what we're going to spend most of the time talking about is common pathologies that you can expect to see in your client population. So the spine, shoulder complex, knees, and then we'll try and just kind of touch on general other points of interest, all right? In terms of demographics, spinal pathology is seen across all demographics and all age groups, okay? It affects people throughout their lives. It is the #1 reason for PT referral, and it has the highest cost to employers. So if you look at those studies, the trunk always came up as the number one area that tended to be injured while people were lifting weights. It's also the #1 area for people who don't lift weights that hurt themselves, right? Majority of people throughout their lives experience back pain in one way or another, whether or not they ever touch a barbell. This study, it's about 20 years old, but it's something that you still see cited a lot today. MRI of lumbar spine in people without back pain, okay? MRI examinations of 98 asymptomatic people. Only 36% of the 98 asymptomatic subjects had normal discs at all levels. Okay, so you can assume when you're working with people that even if they've never had back pain before, there's probably some underlying spinal pathology, all right, whether or not they're symptomatic. So what I want to do is just a quick review of some of the anatomy because, you know, I know not all of us in here have had extensive, formal education in terms of anatomy. Some of you guys are lawyers and work in other fields. So when we're talking about the spinal vertebra, we have the body of the spine, of the vertebra right here, the pedicles right in that area, the lamina, which essentially connect the transverse processes to the spinous process. You guys might have people who come in who tell you they've had a spinal laminectomy, okay? That's a decompression type surgery. If someone has a herniated disc that's impinging on a nerve root or a part of the spinal cord, they'll cut right through that area and remove that, okay, to decompress the nerve root, or the disc. And that's fine, but a lot of those people down the road end up needing a fusion, okay, because you decompress the area, but you sacrifice some stability inherently when you have that procedure. So you might come across that, laminectomy. Intervertebral foramen, obviously that's where the spinal cord travels through. Spinous processes, transverse processes, and superior and inferior articular facets, that is what creates the facet joints, those little synovial joints that kind of connect the posterior aspects of the vertebra together. So we all know that we have a cervical lordosis, a thoracic kyphosis, a lumbar lordosis. The curves of the spine help us to absorb shock a little bit better, right? Works more like a spring. You could have people who have a decreased lumbar lordosis, right? Just a very flat lumbar spine. It's easy to see. They might not be able to tolerate compressive forces as well as someone with a more normal curvature. You could have people with an excessive lumbar curvature, an excessive thoracic kyphosis. That's really common. Again, changes to what we would consider to be ideal are going to affect how the spine is able to handle loading. Okay? In terms of ligamentous support, the spine does have extensive ligamentous support. I just want to draw your attention to the anterior and posterior longitudinal ligaments. So if we look at the anterior portion of the vertebra, and for you guys who are familiar a little bit with spinal pathology and disc pathology, the majority of herniations that cause us problems occur in which direction? The posterior aspect of the vertebra, right? Particularly the posterior lateral portion of the vertebra for a lot of cases. So here we have the anterior longitudinal ligament, which is a big broad ligament across the front of the vertebral bodies that resists spinal hyperextension. And then we have the posterior longitudinal ligament that runs up the back of the vertebral bodies. You can see in relation to the anterior longitudinal ligament, it's much thinner, okay? So it doesn't restrain the disc as well posteriorly as the anterior longitudinal ligament does anteriorly, all right? So that's part of the reason why we tend to have more disc herniations posterior laterally, but just a small part. In terms of the disc itself, we have the nucleus pulposus, which is the inner portion, right? This is the portion of the disc that has the high water content that redistributes compressive forces. It decreases as we age, okay? The annulus fibrosus is the concentric fibrous rings that surround the nucleus. So I like this picture because you get a good idea about what that disc looks like, but then you also see the spinal cord traveling down the back, and you see some of these peripheral nerve roots. There's not a whole heck of a lot of room there, right? So if you have a disc bulge in that posterior lateral direction, there's a good chance that, you know, it could end up impinging on that nerve root a little bit and causing you sensory, you know, motor problems, things like that. So we're going to get into talking about the pathologies. Spinal stenosis. So with spinal stenosis, the diameter of the intervertebral foramen is decreased, okay? It could be from disc protrusion, but a lot of times it's fibrotic scarring, osteophyte formation, tumor, right? All that stuff can be classified as causing spinal stenosis. A lot of times these people have relief with flexion, okay? So if you have an older client who's got kind of like that posterior pelvic tilt, decreased lumbar lordosis, that's a comfortable position for them. So you have to be careful about how you cue them in terms of their deadlift position, their squat, right? Too much extension for them is going to aggravate their symptoms because it's going to further close down that foraminal space. Scoliosis, very common, right? Sometimes there are extremes to that, but you know, I find more and more that when I do an evaluation on somebody, that there's some sort of rotation in their spine that they were maybe even unaware of, right? It's a lateral curvature, but it's important to note that scoliosis is associated with rotation of the vertebra as well. It's not just that S, right? There's a rotation in the vertebra as well, and there are shear and compressive forces placed on the spine. So stenosis, this is what a nice intervertebral foramen looks like, osteophytic growths that close down on that. And when stenosis gets severe, they can have sensory changes in both arms or both legs, radiculopathy and things like that. So scoliosis, this is what a severe scoliosis can look like. And if you can actually get close enough to see this, you can see the spinous processes here, how they rotate, you know, with the curvature. So the spinous processes are not all lined up like we would like ideally. And this is what a corrective surgery can look like. I've had a patient who had a correction from T1 to L5S1. You know, essentially the entire spine was fused like that. So these people lose the ability to really extend or flex or rotate or do anything like that. So you have to be careful about how you load them, although I doubt you guys will see something that extensive. Spondylosis is essentially osteoarthritis of the spine, characterized by osteophytic growths, decrease in the disc space, right, a loss of disc height as you age. The spine cannot handle compressive forces as well, and can lead to changes in bony alignment and shape. So this is what a nice healthy spine looks like, and and this is what happens when you have spondylosis. So this is what it would look like, cervical spondylosis on MRI. You can see the bony buildup. Okay, that's from increased contact between the bony surfaces, right? There's a loss of the articular cartilage there. There's a decrease in disc height, so you have more compression and you get this bony buildup that develops. Spondylolysis is a congenital weakness in the pars interarticularis, the area in between the superior and inferior articular facets that create those facet joints we talked about. Similar to a stress fracture, essentially, okay? It's a defect on just one side of the vertebra. It's associated with repeated forced hyperextension, okay? This is something you'll see more in a younger population. The patients that I've seen with this diagnosis and the one we're going to talk about next are high school age kids a lot of times, okay? College kids, college athletes who participate in sports like gymnastics or dance. I had a tennis player with a diagnosis like this. I just worked with a hockey player. So if you have a young skinny kid who has this congenital type of weakness in that pars interarticularis, and they can't really control their trunk all that well when they're playing their sport, and they're playing their sport 6-7 days a week for hours on end, they can end up with this type of fracture. So characterized by low back pain, you can have some radiation into the glutes, hamstring spasm or tightness, paresthesias, but that's not typically what I've seen. Mostly it's localized pain in the back. Relief, more inflection, modified activity. A lot of times they put them in an abdominal binder brace for a period of like 4 to 6 weeks. They want them in that. And then after that, you can do whatever you want with them. The kid who's a hockey player, I have him squatting and deadlifting and doing all that stuff now. So, and he doesn't have any pain. Now to take that one step further, we have spondylolisthesis, okay, which is the same injury, but it's on both sides, okay? It's a bilateral defect of the pars interarticularis. Now the problem with this is that it's characterized by an anterior displacement of the vertebral body, okay? Usually at L4 and L5 or L5S1, because those are the lumbar vertebrae that handle the largest compressive loads, right? Similar type of presentation. Grades 3 and 4, so they grade these 1 through 4, all right? Grade 1 is just a 0 to 25% anterior slippage. You guys probably work with people who have a grade 1 spondylolisthesis and may not even be aware of it. Once you get into that grade 3 and 4 where you have 50%, 75% or more displacement, those are people who require surgery to stabilize a lot of times. So this is an image right here. It's L5. That's 50% of the vertebral body at least slipped anteriorly. So in terms of disc pathologies, there's different terminology that they use depending on the nature, but you don't really have to get caught up in that. You'll see the term bulging disc. You'll see, disc prolapse, extrusion, sequestrated disc. It doesn't really matter. Again, what you're concerned about is the symptoms. You can have a bulging disc with no disruption of the annular fibers, but if it's impinging on a peripheral nerve root and giving you sciatica, then it's important, right? You can have a herniated disc that doesn't do that and doesn't cause you any symptoms, so it doesn't really matter all that much. But herniated discs generally occur with fatigue failure, right? Repetitive poor mechanics over and over and over again. There are plenty of people who sit at a desk for 8 to 10 hours a day who develop herniated discs, without ever pulling a 1RM deadlift, okay? The problem is they're difficult to heal. Discs aren't very vascular. You get fibrous changes to the nucleus pulposus so they can no longer, imbibe fluid. And the pain is from increased pressure a lot of times. So anybody in here ever have a problem, a disc type problem where they had, really bad sciatica flare up or maybe going down the arm if it was a cervical problem? A couple of you guys in here. How long did it last for? What? Surgery? Till now? So how long before you had surgery?
It happened twice. The second time they took care of it about 5 days after.
About 5 days after it started. Did you lose any motor function?
I still do. My thumb's numb still. It's a year and a half.
Yeah. Generally, you try and ride these things out unless you have a loss in motor function. Once you start to have a loss in motor function, they try and get you in for surgery relatively quickly because the longer you let that linger, there's no guarantee you're going to get it back, right? So, but if you can ride it out, a lot of times the disc just dries out. You lose some of that compression on the area and you feel better, right? Matt Reynolds had an issue a couple months back where he was emailing us, right, about sciatic pain. And, we kind of gave him some advice to get him through that acute stage. Didn't hear from him for a while. The next thing I saw, he was in North Korea deadlifting 660 for a double. So, you can move past these things, despite having, a disc herniation or something like that. And Matt, on his images, he had a little bit of loss of disc height, right? He had a little bit of rotation in the vertebra and that sort of thing, but, it doesn't stop him from training. You just have to manage these types of flare-ups when they happen. So here we have what looks like a pretty healthy spine, although you see some anterior bulging here. Generally, the lumbar spine looks pretty good. This is a spinal cord. And here you have, pretty obviously herniated discs in the other slide here. So L5S1, that's the most common segment for herniation in the body. So in terms of treatment, controlled rest, right? Matt, when you first hurt yourself, what could you really do? Not a whole heck of a lot, right? Anything you do is really irritating in that initial acute stage, so you have to be smart and let yourself rest a little bit. You want to educate people about positions to avoid and lifting mechanics, okay? You'll have people that literally don't know that they shouldn't be lifting stuff, you know, bent over from their spine. Flexion and rotation combined is the most stressful thing that you can do to a herniated disc in terms of applying pressure to it. So you need to avoid that as much as possible. You want to build stability in the area of the herniation, right? Mobility above and below. So what does a squat do? Develops mobility in the hips, develops that ability to hold the spine stable under a load. Posture re-education. The goal is to have progressive centralization of symptoms. So if you have symptoms down to your toe, that's pretty bad, right? If it only goes down to the back of your knee, that's a little bit better. Ideally, you'd want to just have symptoms in the back and then eventually nothing. But you know, the biggest thing in terms of the mechanism of injury, it's repetitive, poor mechanics, right? In my opinion, in terms of training your clients, I don't do any repetitive flexion extension type exercises with my clients. They don't cause any sort of meaningful adaptive stress, right? And they mimic the mechanism of injury to the disc. I think that if you just did squats, deadlifts, and presses with people and chins and maybe threw in some cleans or snatches, whatever it was to help them get to their goals, that is more than enough to train their core, right? Without adding any sort of sit-ups, back extensions, Roman chair work, anything like that. Even if it doesn't injure them now, it could be leading to an injury down the road, right? So I don't see the point in doing that stuff. So just wrapping up the spine, right? We have to modulate pain. You have to be careful when symptoms are really flared up. You have to control force application. You have to ease back into training, right? And the other thing, guys, you know, even though you're most likely going to be dealing with people that have back pain, if someone is presenting with something that you're not comfortable with, refer them out for a diagnosis, right? Don't ever hesitate to refer somebody out to go get a real diagnosis, to go get meds. Don't try and play a role that you're not comfortable with in terms of dealing with a client who has an injury, okay? Some of this stuff can get pretty serious. I mean, you mentioned cauda equina syndrome, right? If you have somebody who has back pain and then all of a sudden they're telling you they you know, have a bowel or bladder problem, I mean, that's a medical emergency that you have to get them out of your gym into a hospital, okay? I had a guy one time who came for back pain who all of a sudden said, you know, he wasn't able to urinate anymore. I said, well, you know, your physical therapy is over and it's time to go see a doctor. And he ended up needing a surgery. So, you know, he came to PT that day and just like casually mentioned that. And I was like, all right.